not leave the journey of studying. I can understand the duration has been prolonged, but still, the only thing that is going to help you is persistent effort, right? And another thing is believe in yourself. Whatever you have read is more than enough. Only the thing that is needed for now is revision of the things that you have read and boosting the subjects which are weaker for you, right? So magic is believing in yourself. If you think that you can make it happen, you will make it happen. So this is the magic that works once you have that faith inside you. And it does not matter how slowly you are going. What matters is of not giving up, of not stopping the journey. So I think, yeah. So we are there. Some people have joined. So let us see a very recent one, which has been just asked in your INI CET. So X-rays of paranasal sinuses are especially your high yield and the important topics that has been asked in almost every exam. Now, if you ask me how much clinically they are relevant, clinically, X-rays of nose and paranasal sinuses are not that much relevant. Why? Because if you see, or if your examiners ask, what is the investigation of choice for a radiology of nose and paranasal sinus, it will be your NCCT, non-contrast CT scan of nose and paranasal sinus, right? So this is the investigation of choice, but your examiner might be too old that he is still asking the X-ray. So anyway, we need to clear this exam, and let us see your recent INI CET question. The radiograph shown below is done for better assessment of frontal sinus. What is the common name of this view? So one time they will ask what is the best view for maxillary sinus. Another time they will give you an X-ray and ask you what is the view. And now this time they have asked you frontal sinus best view. So if you see this X-ray, and if I start a poll, let us see how many of you are right in this, right? Yeah. So if you can see, just answer the poll. Waters view, Calvel's view, Rees view, and Piries view. So we'll come to its answer, but let us see what are the different X-rays that you will find for your paranasal sinus. So Waters view, the most commonly done, which is best for maxillary sinus, right? Caldwell's view, which is best for your frontal sinus. Lateral view, which is mostly done for seeing all the sinuses. So in lateral view is the one view where you can see your frontal, you can see your anterior ethmoids, you can see your sphenoid sinus behind, and you can see your maxillary sinus. Which sinus won't be visible is your almost posterior ethmoids is also visible. So you can say all the sinuses are visible. Then there is one submento vertical and right and left vertical. So one by one we will see. Waters view, another name is occipitomental. So you can write also, right? So if you write also, it will be better for you to remember. So it is occipitomental view. Now they can ask you two type of question among it. One is by giving the X-ray and asking ki what is the best sinus to be visualized in this X-ray. Another is giving this X-ray plate and the position. So they can ask you ki what is means in spite of giving the X-ray, they can give you this image and they can ask you ki what imaging is being done and for which sinus. So it is your Waters view for best for maxillary sinus. So Waters view is best for maxillary sinus. Ethmoids and frontal are too far from the film. That is why it is not very much appreciated. Although you can appreciate your anterior ethmoids, but posterior ethmoids are not at all seen. So here the angle you can see with the vertical is 45 degree, right? Occipitomental. So the literal meaning is occiput and mental will be like this. So rays, X-ray beam will be vertically over the occipitomental line. What structures? Maxillary, frontal, sphenoid, zygoma, zygomatic arch, nasal bone, and all these are not much important, but these are the things that you can appreciate. If you ask me the X-ray, this is your frontal, maxillary sinus, right? And if it is with open mouth, it becomes what view? So it's a revision question for you because it has been already asked. It is if this occipitomental view is with open mouth. Let me see how many of you can answer. If this occipitomental view is with open mouth, means if here in this image, this person has kept his mouth open and the purpose was to see the sphenoid sinus. So with mouth open, you can see sphenoid sinus and that view will be known as, if you can tell me, that view will be known as Piries view. So our one of the option in that question was Piries view. So Piries view is nothing but occipitomental view or Waters view with open mouth, so that we can see the sphenoid sinus also. So if the mouth is open, you will be able to see here two sphenoid sinus also, and then you can appreciate here your zygomatic arch and other things, right? This is your orbit. Now coming to another view, that is Caldwell's view, which is occipitofrontal view. What is important for you to note is the angle. There it was 45 degree, here it is 15 to 20 degree caudally. So nose and forehead will touch the film. So person will be like this in spite of this, right? So nose and forehead will touch the film, and the angle to which the beam will be projected will be 15 to 20 degree. So just keep in mind this view. This is for Caldwell's view. Caldwell's view, and best sinus is frontal, right? So frontal sinus is best, and I think that by now you must have got your answer. So in that question, which was asking which view is best, and they have given the X-ray, it was frontal sinus, right? So this is your Caldwell's view, which is best for frontal sinus. What else you can appreciate is your ethmoid sinus, maxillary sinus, then zygoma, superior margin of the orbit, lamina papyracea, and superior orbital fissure. Now, can you tell me what is this lamina papyracea? If I ask you, where in this X-ray is your lamina papyracea? Anybody? So wait, I can see your comments. Yeah. So anybody, where is your lamina papyracea, and what is this structure? Yes. So it is basically a thin papery. So it's a paper-like bone which separates the orbit from the nasal cavity, right? So lamina papyracea is a thin papery-like bone which separates the orbital cavity from the nasal cavity. So once you do your endoscopic sinus surgeries, you can appreciate your lamina papyracea, and the trick is not to breach this lamina papyracea, not to injure this thin plate of bone. Why? Because if you injure this thin plate of bone, you will enter into the orbital fat and the orbital cavity. So this thin plate of bone that is here, that this line you can see, thin bone, is your lamina papyracea, medial border of the orbit. Very right. So this is again the X-ray that was given in the question. So our answer becomes Caldwell's view, right? So here the answer to that question becomes Caldwell's view. So this was a question from your INI-CET. So starting from your NB NEET to AIIMS to INI-CET, everywhere this X-rays are there. So I don't want you to make mistake in the future questions. Perry's view, by now you know that it's a Waters view, which is just with the mouth open so as to see the sphenoid sinus. Now another view is lateral view. So lateral side of his skull lies against the film and X-ray beam is projected perpendicular. So fluid level of all the sinuses can be seen in this. So this is the position of the patient with the X-ray film and the X-ray beam being projected in this direction, right? So structures that you can see: anterior and posterior sphenoid, frontal, maxillary, sella turcica, ethmoid, alveolar process, condyles of mandible, right? So if you see here, this is your maxillary sinus. The topmost, the superior most will be your frontal sinus. Behind that and in between will be your anterior and posterior ethmoids. The posterior most will be your sphenoid sinus. And if you can appreciate here a groove or a depression here, which is your, what is this? So this is your sella turcica, right? Yes, right, sella, right, great. And coming to that, our fourth option was Rees view. So as you told already, Dr. Shilpi, you told it's for seeing the optic foramen. So this is an X-ray, not for paranasal sinus, but for some other purpose. Now submento vertical view. So this view is taken with the vertex near the film. So this is the vertex and it is near the film. X-ray beam projected at right angle to the film from the submental angle. So this, if you get this picture in the exam, you will mark it as submento vertical view, right? And what structures again you will be able to see? You will be able to see sphenoid, you will be able to see posterior ethmoid and maxillary sinus, right? So best will be your sphenoid sinus. So now they can ask you, they can give you this X-ray and they can ask you, what view is this or which sinus is best seen? So this is your submento vertical, and which sinus is best seen? It is your sphenoid sinus, right? So if you see for maxillary, it was Waters. For frontal, it is Caldwell's view, and for sphenoid, it will be submento vertical view, right? So here you can appreciate your roof of the bony. This is your roof of the bony orbit. These are your nasal septum, lateral nasal bones, and your tooth, mandible, and others thing, right? So sphenoid will be here, somewhere here. So best seen is sphenoid, posterior ethmoid, and then the maxillary sinus. This is again a view of submentovertical, not very much appreciated here. One more views is there, that is Townes view and reverse Townes view. So can anybody tell me where you have seen your teachers giving this reverse Townes view to your patient? With what complaints and in which condition? For what structure you want to see that you give your patient this reverse Townes view? What is particular structure you want to see in this reverse Townes view? So anybody? Okay, so let us see what is Townes view. So Townes view is basically this X-ray which you can see, and what all you can see both the petrous pyramids of the temporal bone, right? And you can see foramen magnum through which your dorsum sella is projecting. So initially when the CT scans were not much there, people used to see this Townes view for all these things. But nowadays CT scan has been there and people use it. Now this is the plate, that is the patient's position with the plate and the X-ray beam for the reverse Townes view. So I was asking you, what is the condition? So we particularly give this X-ray to see a process, that is styloid process. So many a times at OPD, our patients comes with a foreign body sensation in throat. So persistent foreign body sensation in throat, and on palpation, on digitally palpation. So you can be given a picture with the doctor having gloves and palpating near the tonsillar fossa. So what he is doing is basically what he is trying to see is he is trying to palpate the tip of styloid process in the tonsillar fossa. So what happens is, if we assume this is our oral cavity, this is our tongue, and these are our two tonsillar fossa. So basically in the bed of this tonsillar fossa, we try to palpate our styloid process, and it is only palpable if this styloid process is elongated, right? So we try to see elongated styloid process by doing this clinically. We insert a finger with the gloves, we insert the index finger and palpate in the tonsillar fossa to see for elongated styloid process. So this is the thing which we do clinically, and for seeing it in X-ray, we give reverse Townes view. Now if this is your reverse Townes view, or in this Townes view also, you can see this is your styloid process, right? So somewhere here you will find your styloid process. So if it is too elongated, then many a times we have to remove the tonsil and then cut or remove the elongated part of styloid process. The procedure is called styloidectomy, and it is done in, there is one syndrome that is associated with elongated styloid process. Anybody? Yeah, very good. So it's Eagle syndrome, right? So in Eagle syndrome, we find our elongated styloid process, and this is the view that you are not going to forget. This is your reverse Townes view. Now there are some pathological X-ray. First of all, tell me what is this view and what pathology can you see? So if you don't see the blue portion, just tell me what is this view. So this is your OM view, occipitomental or Waters view, right? And if I ask you what is your provisional diagnosis by seeing this X-ray, so what you will say? If you observe your bilateral, so your bilateral maxillary sinus are opacified. It is not black. And how you compare it? You compare it with same-sided orbital cavity, the fat that is there. So basically both are opacified, a provisional diagnosis of bilateral maxillary sinusitis. So these days they are giving a normal X-ray. In future what they can give is a pathological X-ray like this. So again, if you don't see the blue portion, and just let me know the diagnosis. So what diagnosis you are getting from this X-ray PNS occipitomental view that is given to you here. So it is right-sided, right? So right side is opacified, left side is almost normal, right? So if you appreciate your same-sided orbital cavity and the maxillary sinus, these both are pretty same. But if you observe this side, this is pretty opacified. So it is right-sided maxillary sinusitis. So yes, you do find individual sides. So you do find unilateral sinusitis also. Now, so basically these were for PNS, sinusitis and all. So for nasal fractures also we can do some X-ray, and these are lateral view, occlusal view and Waters view. So in Waters view also you can appreciate your nasal bone fracture. So nasal bone fracture is also an emergency where you need to manage it either before the swelling appears or after the swelling disappears. So if you get a patient or a case with nasal bone fracture, you have to either manage it before the onset of swelling, so that is before 24 hours, or if the swelling has appeared, then after 5 to 6 days, when the swelling disappears, you do the nasal bone fracture reduction. Why you do so? So are these diagnoses to be confirmed? Definitely. These are just a provisional diagnosis. So ideally, for confirmation, you have to do a CT scan. So nowadays, NCCT of nose and PNS is the ideal investigation, right? So we say a lot, means your previous year NEET PG questions were based on investigation of choice. So if anybody asks you investigation of choice for sinonasal pathologies and all, so it is NCCT of nose and paranasal sinus. So definitely I would like to go for an NCCT of nose and paranasal sinuses to see where the pathology is, why this sinusitis has appeared, at what level there is obstruction of osteomeatal complex and other things, right? So coming to the topic, lateral view for nasal bones, we can do a lateral view for occlusal view and the Waters view. And I was discussing regarding the management, either you manage it before 24 hours or after 5 to 6 days, because if the swelling appears and you operate, there will be a lot of bleeding and pain to the patient. So you don't want bleeding and everything. So you either do it before the onset of swelling or after the swelling disappears. What it is basically, it is fracture nasal bone reduction. Yeah. Now, so in these x-rays, which are the lateral views, what you can appreciate here is a fracture in the nasal bone, but it is not depressed. And here also the fracture is there, but it is not depressed. So many times it can be non-displaced fracture of nasal bone, or it can be displaced fracture of nasal bone. Occlusal view of nasal bone will look like this, where also you can appreciate the nasal, that is the septal part of nasal septal part of nasal septum, the cartilage part and the bony part, right? So film is held perpendicular between the teeth and the X-ray beam is projected perpendicular to the film. So it shows the fracture line and the lateral displacement of the nasal pyramid clearly. This is again a lateral view showing a displaced fracture of nasal bone. Now again coming to a recent question of INI-CET, which we have already read. So if you see my previous sessions of CT scan of nose and paranasal sinus, we have talked about how we will differentiate between the nasal septum and the turbinate. So here, although it is mentioned, I just want from you to know why it is nasal septum and why it is inferior turbinate. So this type of endoscopic picture was given in your INI-CET. For those who have given, they must know it, and for others it might be new. So this is a picture from diagnostic nasal endoscopy. Now can you reason me why it is inferior turbinate and why it is nasal septum? How you are going to differentiate and know that this is your nasal septum and this is your inferior turbinate? Now for someone who is holding the endoscope, it is easy. Why? Because he knows in which nostril he is inserting the endoscope. But if you are giving only this picture, you have to know that mostly your nasal septum will be the straight one and your turbinate will be a projected or projection, that will be your turbinate. Now if I give you this image, now tell me which is your nasal septum and which is your turbinate, because this is also projected and here also you can see a projected thing. So it is very difficult to tell which one is turbinate and which one is septum, right? So how you will know this? Just know the definition of turbinate. So what is turbinate? Turbinate is a bony shelf-like structure from the lateral wall of nose. So if it is a shelf, it will be enclosing a hollow space within it. So if you see a hollow space enclosed within a shelf, then that will be your turbinate. So your lateral one will be the turbinate, which will be having the space. So this is your inferior turbinate, and the straight one will be the opposite to one will be your nasal septum. Now what is this that you can see behind the inferior turbinate? So septum has no projection, definitely, but if you see here, the septum has a spur, right? So in these type of pictures, it becomes difficult to differentiate which one is inferior turbinate, which one is septum, because both are projected. So you need to see little, because the exam question was similar to this picture where both were projected, but in one side you had this hollow space which was denoting that it is a turbinate, and in the other it was just a projection in the septum. So many a time septal spurs can also be there, and thus you should know that turbinate will be enclosing a space within it, while the septums will be either straight or a spur might be there. So I was asking, what is this structure which I labeled with M? Yeah, so this is your middle turbinate. So as you know, there are 3 passes of diagnostic nasal endoscopy. So in this picture, we have just entered the endoscope inside the nostril, and we can see the inferior turbinate, nasal septum, and the middle turbinate. Now, if you move more forward, if you insert the endoscope more forward along the roof, along the floor of the nose, and move posteriorly, that will be your first pass, right? So if you move along the floor of the nose, you will observe that you will be seeing this middle turbinate, and this will be a better picture where you will be seeing a middle turbinate. Your lateral, now inferior turbinate, will be below nasal septum. And if you go along the floor till posteriorly, what you will get? In the posterior end, you will get choana. So as we move forward, we will see how the choana and that picture looks like. But for now, just remember that anything which will be holding a space will be your turbinate, opposite will be septum, and this is your middle turbinate, right? So turbinates, you know, these are the ends of bony lamella, and these all you know. This also you know which all things open in the middle turbinate, which all things open in the inferior meatus, and which all things open in the superior meatus, right? So do I need to tell you? If yes, then comment. I'll just tell you because this is very basic and I don't want to waste any of your time. Now, inferior turbinate. So one thing that is important regarding inferior turbinate is it is the largest turbinate and the largest meatus. Another thing is it is a separate bone. That means it is not a part of ethmoid bone. It is a separate bone covered by the thick mucous membrane with irregular surface. Nasolacrimal duct opens, but the important thing is where this nasolacrimal duct opens. So it opens in the anterior portion of the lateral wall of the inferior turbinate, around 1 centimeter, right? How much anterior? So around 1 centimeter from the anterior end of the inferior turbinate. So this is the location of the nasolacrimal duct opening, and it is guarded by a valve. Can you name me the valve? The valve is valve of Hasner. Now, they are again very fond of giving the CT scan picture. So if I label this, can you tell me what is this structure? Bilaterally, you can see in the axial cut. So this is an axial CT scan of nose and paranasal sinus, where what all structures you can see. Let us see the normal structures first. So this is your cartilaginous part of the nasal septum. This is your bony part of the nasal septum. This is our black part, is your maxillary sinus, right? This is your zygomatic arch. What else you can appreciate? You can appreciate inferior turbinate. This is your choana that I was talking about. Once you move back, you will reach the choana. And this is your maxillary sinus. Now, what is this structure which is enclosed inside the inferior meatus? So this is bilaterally, this is your opening of the nasolacrimal duct. So only in the axial scans, you can appreciate this nasolacrimal duct opening. In the other cuts like coronal and all, these are visible, but for best view, it is the axial view, right? So in the axial scans, you can visualize your nasolacrimal duct. Wait. Yeah. Concha bullosa, I am coming to it. Ager nasi was another question that was asked in your AIMS examination. So you can say it is the most anterior ethmoidal air cell, right? And how you will see it? This is your middle turbinate, right? So once the middle turbinate attaches with the lateral wall, you will see a projected end here, right? So this is if this anterior most ethmoidal cell is pneumatized. That means if it has air, then only it is the Ager nasi cell. Now, if you see this cut, this CT scan, let us appreciate the same thing in a CT scan, right? So here you can see this cell. So this is your Ager nasi. And if I ask you why it is not bulla ethmoidalis, so bulla ethmoidalis is also a pneumatized ethmoid air cell which appears like this. Why it is a Ager nasi, the anterior most cell, and not bulla ethmoidalis? Anybody? Why this cell is Ager nasi cell and not bulla ethmoidalis? Yes, you can say that maxillary sinus has not yet appeared. So you just see how a coronal cut is being taken. So coronal cuts are being taken like this. One will be this. So as we go posterior, things will appear. So most anterior will be your frontal sinus. Now once frontal sinus start disappearing, your maxillary sinus and other things will appear. So here if you observe, your frontal sinus has appeared, but maxillary sinus has not yet appeared. And as maxillary sinus has not yet appeared, it is the anterior most cut where you can see nothing else but the anterior most ethmoidal cells, right? So it is your agar nasal cell. Now coming to the middle turbinate. So I think that by now you only know middle turbinate, but I want you to tell that middle turbinate has three attachments. What are those three attachments? These three attachments can be remembered by a mnemonic called school. So S is sagittal, C is coronal, and H is horizontal. So these are the parts of middle turbinate. If you see, middle turbinate is not straight. Once you enter the nose, you encounter the first part, that is sagittal. So whatever you were seeing here, this was the sagittal part. Sagittal means this. So this is the sagittal cut, right? So if you take a CT scan, these are the sagittal cuts. So this is a sagittal. Now once you progress more, you will encounter a coronal part. So this middle turbinate, what it does is, it is like this in the anterior part, and then it curves like this. So this is the coronal part, that is C, second part, coronal, and then it becomes horizontal. Then it becomes horizontal. So this is the third part, right? So these are the different parts of the middle turbinate that can be asked by CT scan. Now, if you see that we were talking about, this is what a middle turbinate really looks like. So this is your sagittal part, then will come your coronal part, and then is the horizontal part. Middle turbinate shows different variation. One you all know, that is concha bullosa. Another that I wanted to tell you is paradoxical middle turbinate. What is paradoxical middle turbinate? Paradoxical means opposite to the normal. What is opposite to the normal? Opposite to the normal is, if you see, a normal middle turbinate is bulged towards the septum side, right? But if it is bulged towards the middle meatus, like here, right, it will be a paradoxical middle turbinate. Normally middle turbinates are this side, they are bulged this side, but if they are bulged towards the middle, towards the maxillary sinus ostium, then it will be your paradoxical middle turbinate. Now here you can see simultaneously two things. One is concha bullosa and another is paradoxical middle turbinate. So both, because of concha bullosa pneumatization in the middle turbinate, it has also shown to block the osteomeatal complex, right? So this type of scans, here if you see on the left side, the middle turbinate is normal, but on the right it is pneumatized, and that is concha bullosa, very common, and most of you know this. Yes, I know. Now coming to another important structure that you need to identify in a CT scan is uncinate process, right? So it is a boomerang shaped structure that is sagittally oriented. Now to give you a better idea, let us see this endoscopy picture. This is our septum, this is our middle turbinate, and this structure that you are seeing here is your uncinate process. So it is your placed like a, this part is coronal. So uncinate also has three parts, right? One is your vertical part, another is horizontal part, and the middle one is intermediate part. Now one question arises, why I am telling is, there is one question with regard to uncinate. You all know a very common step, or the first step of endoscopic sinus surgery or a functional endoscopic sinus surgery is uncinectomy, right? So if I ask you, what is the first step of FES? So we all know that this FES is a management of choice for most of the sinonasal diseases like polyposis and all. So what is the first step? First step is uncinectomy. So if I ask you at which part of this uncinectomy begins, so that will be your intermediate part. In the intermediate part, we start the cutting of uncinate to enter into the infundibulum, right? So that is why it is important for you to know the parts of uncinate. First of all, try to identify the uncinate process. So if you see, the blue marked structure here is uncinate process. And what is the structure that you can see here? Can you tell me what is the structure that you can see here? This one? Anybody? Behind the uncinate, just behind the uncinate, you will find a groove or a space, that is infundibulum, that will lead into the maxillary sinus ostium. But behind the uncinate, there is one ethmoid air cell, that is not inferior turbinate, that is bulla ethmoidalis. So here if I erase it, yes, right. So this is bulla ethmoidalis. So you need to identify this picture, and the best way is to see the video of diagnostic nasal endoscopy. So if you remind me, I'll post it in the group, the video of diagnostic nasal endoscopy. So this structure, if you can see, is your bulla ethmoidalis. This is uncinate process. So once we remove this uncinate process, we will be able to find our maxillary sinus ostium, and we will do maxillary sinus, means enlargement of this ostium, that we say middle meatal antrostomy. That procedure is called middle meatal antrostomy. We have opened the maxillary sinus ostium, and behind is the bulla. So if we have to do anterior ethmoidectomy, we have to open the bulla. Why? Because bulla is the largest, you can say, anterior ethmoid cell. Now here what you can say is different attachments of uncinate. So the attachments of uncinate is the second important thing with regard to uncinate. Why it is important? Because the frontal sinus drainage depends upon the attachment of uncinate process. So if you see, it's very easy. It looks complicated, believe me, but it is very easy. If you look this picture here, you can see this is your inferior turbinate, inferior meatus, and this is your uncinate process. Right now, just see where the uncinate process is attaching. This is your orbit. So if you see, this must be your lamina papyracea, medial wall of orbit, already explained. So just see where this uncinate process is attaching. So it is attaching to the lamina papyracea, and your frontal sinus, this is your frontal sinus. Frontal sinus is draining into the, or you can say draining medial to the infundibulum, draining directly into the nasal cavity. Right now, this uncinate can be attached to the middle turbinate. It can also be attached to the skull base, like in this figure. So if you see here, the uncinate is not attaching to the lamina papyracea, but it is attaching to the skull base or the cibriform plate. This is your cibriform plate. If you ask me, this is your medial lamella of the cibriform plate. This is your lateral. So vertical is your lateral, and this horizontal is your medial lamella. This is your medial lamella. This is your vertical lamella of the cibriform plate. So here uncinate is attaching to the cibriform plate or the skull base, and just see that frontal sinus is draining into the maxillary sinus. Right. So if uncinate is attached to the skull base or cibriform plate, or if the uncinate is attached to the middle turbinate, like in this picture, if you see here, so here the uncinate is attaching to the middle turbinate. So in both the scenarios, if it attaches to the middle turbinate or if it attaches to the skull base, the frontal sinus is draining via the maxillary sinus. What is the significance? The significance is, in both the case scenarios where the uncinate is attached to the skull base or to the middle turbinate, a frontal sinus infection will cause a concurrent infection of the maxillary sinus. So a frontal sinusitis will lead to maxillary sinusitis. Why? Because of the common drainage pathway. If you see, if there is any infection in the frontal sinus, it will also cause maxillary sinus infection, because the draining pathway is common as uncinate is attached to the middle turbinate or to the skull base. So this is the significance. They can ask you in a variety of ways by giving a case scenario where the patient is presenting to you with the frontal as well as maxillary sinusitis. They can give you the CT scan and they ask you what might be the reason for concurrent sinus infection. So these are the way in which they can make you confused. Right. So here also, if you see, this is your uncinate process. So this is a way that how you identify your uncinate process. This is your inferior turbinate. And we already saw that this was your bulla ethmoidalis. This is our star marked is our uncinate. Here the middle turbinate is being retracted with a instrument, that is a Freer's retractor, so as to see the bulla ethmoidalis more clearly. So ethmoid bulla is the most constant, right? Most constant. So bulla will always be present. Your agar nasi might or might not be present, but most constant and biggest anterior ethmoidal cell is your bulla ethmoidalis, largest anterior ethmoidal cell. Now if I ask you, I have been teaching it in my previous classes, how you differentiate anterior ethmoids from posterior ethmoids. What is the surgical demarcation line that you say that anterior to it is your anterior ethmoid, posterior to it is your posterior ethmoid air cell? Anybody? Let me see how many of you have that knowledge. So the line or the demarcation is your basal lamella. That line is called basal lamella. So they can give you a MCQ like anterior and posterior ethmoidal cells are separated by a bony landmark that is called basal lamella. And if you remember, I have told you middle turbinate has three parts. That is remembered by school, SCH. So the C, that is the coronal part, is your basal lamella. So the basal lamella is formed by middle turbinate. The coronal part of middle turbinate forms this basal lamella. So basically this was a middle turbinate. When it goes laterally and attaches with the lateral wall, this is your ground lamella. So anything which is anterior to it is your anterior ethmoid. Any ethmoid cell which is anterior to it is anterior ethmoid. Any ethmoid cell which is posterior to it is posterior ethmoid air cell. Right? So if you got this concept, just give a thumbs up. I'll get to know that yes, you got this. Sure. Great. Hiatus semilunaris, you all know that it is a two-dimensional space which leads into infundibulum. Right? And infundibulum has a maxillary sinus ostium. So hiatus means gap or cleft or passage or way, right? So it gives way to a infundibulum or a three-dimensional space. So if you assume this room as infundibulum, the gate that you can see this way is your hiatus semilunaris. It is a two-dimensional space which leads into the room or the infundibulum, where at one corner you will find the maxillary sinus ostium. And osteomeatal unit is a complex structure that is found by different structures collectively, like uncinate process, ethmoid, this infundibulum, your hiatus semilunaris, bulla ethmoidalis. So all these things leads into the drainage or helps into the drainage of maxillary sinus. So in CT scan, we have to see whether this osteomeatal unit is blocked or open. So in the middle meatus, you will find this osteomeatal complex, which is important for the drainage of the maxillary sinus. Now coming to the ethmoid infundibulum by a CT scan. So here you can see your middle turbinate. This is our bulla. This is our uncinate. So between the uncinate and bulla will be hiatus semilunaris, which leads into the three-dimensional space that is your infundibulum, right? And here will be somewhere your maxillary sinus ostium. If you see in this picture, this is our inferior turbinate. This is our pneumatized middle turbinate called concha bullosa. Here you can see attached to the inferior turbinate is your uncinate process. This is a pneumatized anterior ethmoid air cell, that is bulla, and between the bulla and the uncinate we will find our hiatus semilunaris leading into the infundibulum and finally into the maxillary sinus ostium. Right? So between the uncinate and the bulla is our hiatus semilunaris leading into the infundibulum. So these are the different ways by which we can appreciate our infundibulum and the maxillary sinus. Another very, very important thing is your anterior ethmoidal artery. This is the artery that if you ask any first year or second year ENT resident, they'll be fearing it. Why? Because while doing endoscopic sinus surgery, it is high chances that a premature surgeon does damage to this artery. And what happens is emergency question can arise for your NEET PG. What emergency question? The emergency question will be a surgeon doing endoscopic sinus surgery suddenly observes bulging of the eye of the same site. So I'm just giving you a case scenario where a surgeon who was doing a functional endoscopic sinus surgery observes bulging of eye of same site. So can you tell me the reason why it is happening? It is happening because of injury to this anterior ethmoidal artery. So this ethmoidal artery, anterior ethmoidal artery, if injured, what happens is it retracts into the orbital cavity. And once it retracts into the orbital cavity, it keeps on bleeding. So as we all know that orbital cavity is a closed cavity. If some artery bleeds in it, then it will cause compression of the orbit, and where the orbit will move, it will protrude from the orbital cavity. And that is why while doing this endoscopic sinus surgery, you will observe that the surgeon keeps the eye open of the same side because he wants to know if by any time he has injured the anterior ethmoidal artery, right? So how you will identify what is the site of anterior ethmoidal artery? So a very important landmark is there. Can I know this landmark that is marked with the arrow? So just think that this arrow is there in the question and it has come in your NEET PG 2021. That have a very high probability. So just tell me the answer. What is this landmark known as? I'm giving you just few seconds. So this landmark is known as Kennedy's nipple. So it's a very famous landmark called Kennedy's nipple. What it denotes is, it denotes the exit site. Yeah, it denotes the exit site of the anterior ethmoidal artery from the orbit. So if you see from the orbit, your anterior ethmoidal artery will be exiting from here and then again getting inserted into the cranial cavity. And another thing is, it exits between the two muscles, that is superior oblique and medial rectus. So this is another important thing, is in the CT scan you can observe two muscles, one is superior oblique and the medial rectus, and between it your anterior ethmoidal artery will be exiting. And how you will know that? You will observe this Kennedy's nipple at the exit of the anterior ethmoidal artery. So why it is important for the surgeons to see? Basically we see whether this anterior ethmoidal artery is covered by bone or not. Usually this artery is covered by a covering of bone, but many a times this bone covering is absent, and then it will be just like a mucosal tag which has a chances of getting injured. So that is why it's important to see your radiology before you operate. So in surgeries like this, radiology serves a great role. It serves to means basically a good surgeon has the map of the operation before he operates. So these radiologies help us to map out the surgery, how we are going to progress, what all things we will encounter during the surgery. Starting from very minute details, we will be getting to know everything through the radiology, right? Now, similarly, behind the anterior ethmoidal artery, we will see the posterior ethmoidal artery. Now, one MCQ is there, ki how much posterior this posterior ethmoidal artery is from anterior nasal crest. So anterior nasal crest is this one. So 24 millimeter, you can say 24 millimeter posterior from this anterior nasal crest, you will find your posterior ethmoidal artery. Now, how much posterior to the anterior ethmoidal artery you will find your posterior ethmoidal, means that means if it, just remember, this is your anterior nasal crest, right? This is your anterior ethmoidal artery. This is your posterior ethmoidal artery. Now, this whole distance from anterior nasal crest to posterior ethmoidal artery is 24 millimeter. And distance between anterior and posterior ethmoidal artery is 12 millimeter. Similarly, distance between anterior nasal crest and anterior ethmoidal artery is 12 millimeter. So they can ask anything among it, right? And one more thing is, just behind the posterior ethmoidal artery, one more vital structure is there that they can ask you is your optic nerve. So they can ask you the distance between posterior ethmoidal artery and the optic nerve. So it is 3 to 7 millimeter. So these are the some distance, some landmarks that are being given by different studies, and I don't know why, but it doesn't help in surgeries. But yes, it gives an estimate ki how much behind, means around 1 centimeter behind the anterior ethmoidal artery, you will find your posterior ethmoidal artery. Around 1 centimeter behind the anterior nasal crest, you will find your anterior ethmoidal artery. So these are some questions that you might get in future. So just remember 12, 24, right? So 12 millimeter from here and 12 millimeter from anterior to posterior. So these were the ethmoidal artery, like we were just making you know through the CT scan. Here is a good picture which you can see. This is your superior oblique muscle. This is our medial rectus muscle. Here is our anterior ethmoidal artery, which is exiting at the Kennedy's nipple that we have taught. Now, some cells like Onidi cells and Hellard cells. So these are two cells that you need to know, right? So Hellard cells, you know, it is anterior ethmoidal air cell that is found at the or in relation with the floor of the orbit. Yes, right. So it's found in 10% of the population, which is present in the floor of the orbital. What is the significance? Can you tell me why it is important to know whether the Hellard cell is present or not, and why it is important to remove this cell? So as nowadays things are clinical based, always try to understand the concept before knowing anything. So Hellard cells, if you see this, if this Hellard cell is present, you will observe that your maxillary sinus ostium is getting narrowed. You see, if it would not be here, you will get a wide ostium, wide infundibulum for drainage of the maxillary sinus. So here it is narrowing the osteomeatal complex. So what it is doing is it is hampering in the drainage of the maxillary sinus, which will cause or might cause the maxillary sinusitis. So here if you see, you can see polypoidal change in the left maxillary sinus. Here also you can see polypoidal change in the mucosa of the right maxillary sinus, and here definitely you can see a polyp getting arising. So all this is happening due to the presence of HeLa cells. So you need to remove these HeLa cells and make the ostium wide so as to maintain the drainage. So these all will help you in your future also. Now, anterior ethmoid cells, we all know that there are different types of variation like frontal, recess cell. So supraorbital cell, agonisa, you all know. Supraorbital, I'll show you here. So difference between anterior ethmoidal and posterior ethmoidal, there are two definite differences. One is anterior ethmoidal layer cells are more in number, right? More in number and smaller in size. If you observe in CT scan, this will be more in number, smaller in size, and posterior ethmoidal cells are less in number, 1 to 5, but are larger in size. Now coming to after HeLa cells, the second important cell was Onidi cell, right? So if you see here, Onidi cell, this landmark 1 and landmark 2, which one is your Onidi cell and which one is your sphenoid sinus? Just tell me, 1 is Onidi cell or 2 is Onidi cell. I want to see how much you know about these things. So according to you, 1 is your Onidi cell or 2 is the Onidi cell? What do you think? So I'll just end the session with this Onidi cell. Don't get worried that it is getting prolonged. I'll end it. Yeah. And why? And why? Why? So basically your 1 is the Onidi cell. Why, you will get to know here. So Onidi cell is again a ethmoidal air cell that has extended posterosuperiorly, or you can say posterolaterally. So if you see, this is your sphenoid sinus, and posterior and lateral to it, extension from the posterior ethmoid cell is the Onidi cell. Why it is important? Because you can see a very vital structure coming into relation of it, right? So you are able to watch it now because it is extending, the time is extended. So if you are able to watch, just give me a thumbs up, I'll get to know. Okay, right. So this is the optic nerve. So Onidi cell, O for O. This is the way I had learned during my PG days. So O for O. O for O means Onidi is in relation with the optic nerve, and the other cell is with the relation of the orbital fluid. That is the HeLa cell. So here you can see optic nerve is lying in relation. So if the surgeon opens it thinking it is sphenoid sinus, he might injure the optic nerve directly. So this is the reason that you need to know whether this Onidi cell is present or not. And I'll tell you a very easy way to know it. Just know that usually here you will get a sphenoid sinus where you will get, or if I show you the normal sphenoid sinus, just give me a minute. Yeah, so this is our normal sphenoid sinus. Yeah, this is our normal sphenoid sinus separated by a intersphenoidal septum. If we get any horizontal septation here, then you can think that Onidi cell is present. So here, if there is any horizontal bony septation, then this will be your Onidi cell. If it is also here also, then again it will be your Onidi cell, right? So this is a very easy way. Now, if I have opened this CT scan, I want to tell you 2-3 more points that I had already discussed and it was asked in your recent examination, the structures that are related to it, to the sphenoid sinus. So if you see, below is your choana. Here you can see some part of inferior turbinate, because the posterior most part of the inferior turbinate, because the sphenoid sinus is posterior most. So this is the posterior most cut of the coronal sections, right? So here, with the relation of sphenoid sinus, there are very vital structures like internal carotid artery. So here you can see a bulge of the internal carotid artery. What else? You can see the optic nerve right here. You will see the optic nerve here. So this is your optic nerve, very important. And between the optic nerve and internal carotid artery is your opticocarotid recess. So this is your right opticocarotid recess. This is your left opticocarotid recess. These are some landmarks that they can ask you. So here you can see your optic nerve, internal carotid artery. Now what they had asked in the examination that I was repeatedly wanting you all to know is, here this canal is containing a nerve called Vidian nerve, and the canal is called Vidian canal. The lateral one is your foramen rotundum. So this is the thing that I wanted to tell you repeatedly through my different classes, and it was asked in this INI CET also. So I think those who have attended it, they must have marked it right. The lateral one is foramen rotundum. The medial one, that is more towards the choana, is your Vidian canal. Now I think I must end this because I am already out of the time that was allotted. So basically I just wanted to give you the insights that are being asked and what all future questions you might get. And I'll try to cover not only ENT but all other subjects also, because now What is being asked is your integrated medicine. It is no more about ENT, it is no more about orthopedics, it is no more about medicine or surgery. Everything is now a patient-based question. So a patient who is coming to you doesn't come to you with a ENT or with a surgery or medicine problem only. He comes to you with a case. So nowadays they are being the case-based questions are asked, and I'll see that you get the concepts right so that you are able to answer it in your main exam. Right, so it's already, the class is getting ended. Stay happy and keep giving your efforts, and those will be definitely be answered. Stay happy. Good night. Bye bye.